Hi everyone, welcome to part 2 of the target 31st August 2020. So we are right here actually. The exam is in about 24 hours from now. So we are not going to go into the depth of any of the topics and we need to just quickly brush through our whatever knowledge we have. We just have to go through the MCQs so that we get familiar with them once again. So yes, I hope all of you have seen the video which is the part 1 which was posted before this, and if you haven't, then it's available on the platform. Please do go through it. You always have an option of increasing the speed and going through it because you obviously have a time crunch right now, and this session also is going to be as rapid as the previous one where we are going to discuss a mixed bag of path and microbiology questions. So yes, without a further delay, let's begin with this session. And the first thing that we are going to start with is pedigree analysis. So pedigree charts and inheritance mnemonics is something all of us have to revise. So here we are. There is a pedigree chart that is given right in front of you. You need to tell me the inheritance. So well, if you look at the pedigree chart, first of all, there's a mother who obviously has the disease. This mother has given the disease to 1, 2, 3, 4. Mother has given the disease to all her children. So number one, what do I see in this pedigree chart? It is mother to all. It is mother to all. Okay, in the next generation, when this girl and this girl, when they become mothers, they also give the disease to all their children. So mother to all is a universal thing in this pedigree chart. However, when these boys, they become fathers, they don't give the disease to any of their kids. So can I say father to none? If the father has the disease and none of the children get the disease, but when mother has the disease, each and every child gets the disease. So what is this? Mother to all, father to none means I'm talking about mitochondrial inheritance. I hope everyone remembers the most common mitochondrial inheritance is MELAS. That's also a previous year question. Okay, so basically, why am I telling you this? Because we have to analyze a total of 7 pedigree charts. The first 2, autosomal dominant and autosomal recessive, guys, they have the word autosomal, means no gender related, no sex related problem would be seen over here. It is autosomal, right? Whereas X-linked recessive, X-linked dominant and Y-linked will have gender related problems. So let's see one by one. As I said, when I'm dealing with autosomal dominant versus autosomal recessive, there is not going to be any gender bias because they are autosomal. So how do I identify them? In autosomal dominant, all the generations will be involved, and in autosomal recessive, generations are going to be skipped. Let me show you. So what do I say? Whenever you see a pedigree chart, you have to follow the 2G rule. What is the 2G rule? One G stands for gender and the other G stands for generation. Gender and generation. What do you mean by that? First, look at any gender problem in the pedigree chart. So are only males having the disease? Are only females having the disease? Is there any gender problem? So over here you say male has a disease. In the next generation, male, female, female, and then female and female. So males and females both are having the disease. Gender is not the issue over here. So obviously it's not X or Y related, it's autosomal. Now, are all the generations involved? So first generation affected, second generation affected, third generation also affected. Yes, all generations are involved, means I'm dealing with autosomal dominant. Versus look at the other one. Again, you got a pedigree chart, you look at the 2G rule. First, gender. What do you see in gender? Female affected, male affected. So gender bias is not there. Now what do you look out for? Now you look out for the generation. So first generation is showing you the disease, second generation is not showing you the disease, third generation is not showing you the disease, fourth generation is again showing you the disease. Can I say generations are skipped? When generations are skipped, you are dealing with autosomal recessive. So what's the rule? In autosomal dominant and recessive, there's no gender bias, but in autosomal dominant, all generations are affected, and in autosomal recessive, the generations are skipped. Okay, done with autosomal. Now let's begin with the X-linked disorders. The rule is the same. 2G phenomena you're going to put, 2G rule, gender, generation. First, let's look at gender. Who is having the disease? Here one male has the disease. Here one male has the disease. So usually males are being diseased. Okay. What about carrier? Here a female is a carrier, female is a carrier, female is a carrier. So usually females are being carriers. So there's a gender bias here, right? Usually males are having the disease and females are being carriers, and this type of inheritance is an X-linked recessive inheritance. It is an X-linked recessive inheritance. I hope everyone is clear with this. Moving on. The next one. Again, the rule is the same, the 2G. First, look for gender. So you say, first, father has the disease, okay? After father, the father gives birth to 2 daughters and 2 sons. Both the daughters have the disease. So, father to all daughters. That is the rule that we follow for X-linked dominant. Remember, father to all the daughters, okay? All the daughters. And if daughters further have children, so like for example this daughter further had children, so how many children did she give the disease to? 50%. From daughter, if it goes to 50% of the children, this is in favor of X-linked dominant. So what is X-linked dominant? Father to all daughters, guys, because father is XY, right? Y chromosome will always go to all the sons and X chromosome of the father will always go to all the daughters. So now if father has a problem in the X chromosome, the disease will go to all the daughters. If father has a problem in his Y chromosome, then the disease is going to go to all the sons. I hope it is clear to everyone. Yes? Okay, so here father to all daughters means X-linked dominant. Similarly, look at this. Now, 2G rule, gender generation. Is there any gender problem? Male, 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 male. Each and every male of the family is affected, means father to all the sons. Then again, father to all the sons. So what is the inheritance? Father to all sons is Y-linked inheritance. What was father to all daughters? Father to all daughters was X-linked dominant. Father to all sons is Y-linked, also known as Holandric inheritance, and that is the question you should expect now. Andro will remind you of males. So Holandric inheritance, Y-linked inheritance, father to all the sons. One of the examples of Y-linked inheritance is hairy ears. So yes, you've done 5 pedigree charts. I hope everyone is clear with it. Number 1, you have autosomal dominant and autosomal recessive, where there's no gender bias in either of these. In autosomal dominant, all the generations will be affected. In autosomal recessive, generations are going to be skipped. Then coming to X-linked recessive, usually males are diseased and usually females are carriers. In X-linked dominant, father to all daughters, and in Y-linked, father to all sons. The 5 pedigree charts are done. You are left with 6 and 7. This one I just taught you. When mother gives the disease to all her children, mother to all, right? We just discussed this. Mother to all. So next generation also, mother to all, mother to all. But father to none, that's the rule. Father to none. Which inheritance do you see out here? This is mitochondrial inheritance. This is mitochondrial inheritance. Last pedigree chart. Both the parents are normal and still child is affected. They'll give you a history, parents, grandparents, great-grandparents, everyone in the family is normal and still the child has landed up with the disease. Please remember, this is a classical description of germline mosaicism. This is a classical description of germline mosaicism. I hope it is clear with everyone. Yes, so 7 pedigree charts you've done. This was first thing that you had to revise in genetics. The second thing that you have to revise are all the mnemonics of the inheritances. So let's begin. First, let's begin with the examples of autosomal dominant disorders. And what is your mnemonic? Your mnemonic is, he has a very dominant father. He has a very dominant father. So what is it? He for hereditary spherocytosis. He has H for Huntington's. A for autosomal dominant polycystic kidney disease. V for von Willebrand disease and VHL syndrome. D for muscle dystonia. O for osteogenesis imperfecta. M for Marfan's. I for intermittent porphyria. N and N for NF1 and NF2. A for achondroplasia. T for tuberous sclerosis. Okay, father, FA is for FAP and familial hypercholesterolemia. Familial hypercholesterolemia. So what is it? He has a very dominant father, that is your mnemonic for autosomal dominant. What about the mnemonic for autosomal recessive conditions? So students always use this mnemonic, that is pasta chawal. Okay, it's a foodie mnemonic. Pasta chawal. What is that? Phenylketonuria, alkaptonuria. So two enzyme deficiencies, phenylketonuria, alkaptonuria. Two hemat disorders, sickle cell anemia and thalassemia. So look at this. Phenylketonuria, alkaptonuria, sickle cell anemia, thalassemia. What is with chawal? C for cystic fibrosis, H for hemochromatosis, A for alpha-1 antitrypsin deficiency, Wilson's disease, adrenal hyperplasia and albinism. That is a recent favorite question that has come up. Albinism. A for adrenal hyperplasia, A for albinism, and L for lysosomal and glycogen storage disorders. May I put forward a biochemistry question as well? All the lysosomal storage disorders are which inheritance? Like I'm just teaching you, they are autosomal recessive. However, there are two exceptions to this rule. One is known as the Fabry's disease and the other is known as the Hunter's disease. And these two are exceptions. They are X-linked recessive. They are X-linked recessive. So other than that, all lysosomal like Niemann-Pick, Tay-Sachs, Gaucher's, all are autosomal recessive except Fabry's and Hunter's, which is X-linked recessive. So what's your mnemonic for autosomal recessive? Pasta chawal. Coming to X-linked recessive, coming to examples of X-linked recessive, it's a very wise mnemonic. Wise A, B, C, D, E, F, G, H, like that. So W for the very expected question, Wiskott-Aldrich syndrome. A and B for hemophilia A and B. C for color blindness. D for Duchenne's muscular dystrophy, DMD, Duchenne's muscular dystrophy. F for Fragile X syndrome. G for G6PD deficiency. So it's a wise mnemonic, but am I missing out on anything? Have I missed out those two lysosomal storage disorders? Can I with the F also add Fabry's disease? Can I add Fabry's disease? Yes. And can I then add the last H as well, because the disease which also has X-linked recessive inheritance is Hunter's disease. So I've made final, what is my mnemonic? A, B, C, D, E, F, G, H. I hope it is clear. It is for X-linked recessive. X-linked dominant, remember two most important when I'm talking about X-linked dominant. It is Alport syndrome and vitamin D resistant rickets, the most important. There are more, but more than enough for the exam are these: Alport and vitamin D resistant rickets. I hope all the inheritances and all the PDFs, these I had circulated also to all of you when we were having classes on the Unacademy platform. I hope everyone has mugged these mnemonics and crammed up the pedigree rules that you have to do. Okay, having discussed this, now let's move forward. Now let's go on to talk about the parts of a microscope. So yes, let's begin. Number one, here we go. So that is the microscope that we have, right? That is the microscope. What are the questions you will get? There are two questions that you're going to get on a microscope. Number one, label the microscope. Number two, tell the magnification. So let me tell you, this is a regular light microscope. This is a light microscope. So obviously the first labeling that they will ask you is, what is this? This is a light source. This is the light bulb, okay? This is the light source. Fine. The light goes up. What is this round structure over here? This is the condenser. This is the condenser. Okay. What is this? Where the stage, where the slide is kept. Slide is kept on the stage. If you want to move the stage up and down, you have one big knob which helps in coarse movement, and you have one tiny knob which helps in fine movement. What are the lenses that you have? You have this set of lenses which is known as objective lens. Remember, objective lenses are 4x, 10x, 40x and 100x. 4x, 10x, 40x and 100x. So please remember that is the objectives. And then you have where you keep the eye, over here. This is the eyepiece. This is the eyepiece lens which has a fixed magnification of 10x. So what are the magnifications of these objective lenses? 4, 10, 40, 100. Whereas what is the magnification of the eyepiece lens? It is 10x. So what is the maximum magnification that I can obtain? See, the eyepiece will always give me 10x. Eyepiece will always give me 10x. Objective, which is the maximum one, you can take the 100x. You can take the 100x and then you can multiply it by 10x. So the maximum magnification that I can get from a light microscope is 1000x. I hope everyone has understood this numerical. Maximum magnification 1000x, because from objective you've taken the maximum one, that is 100, and eyepiece can only offer you a 10x magnification. This was light microscope. Now all of you will attempt one question on fluorescent microscope. Which of the following fluorescent stains is correctly matched? Correctly matched. Acridin orange TB, auramine rhodamine malaria, calcoflower white fungus, acridin orange fungus. Which is correct? Calcoflower white for fungus is correct. So we have to talk about fluorescent microscope now. Guys, 3 pet questions of fluorescent microscope your way. Fluorescent microscope uses which light? Ultraviolet light. U for you. Fluorescent uses ultraviolet light. What happens to the wavelength of the light? Question number 2. So question 1, ultraviolet light. Question number 2, it changes from shorter wavelength to longer wavelength, short to long. And question number 3, name the fluorescent dyes. Name the fluorescent dyes for TB, malaria and fungus. For TB, it is auramine rhodamine. For TB, it is auramine rhodamine. For malaria, it is acridin orange. And for fungus, it is calcoflower white. It is calcoflower white. So in your previous question, option 1 was acridin orange for TB. No, acridin orange is for malaria. Exactly. Auramine rhodamine for malaria. No, auramine rhodamine are for TB. Calcoflower white for fungus. Yes. Acridin orange for fungus. No, I have told you acridin orange is for malaria. And for fungus, we have the calcoflower white. I hope it is clear to everyone. Okay, moving on. Now coming to 2 questions pertinent to natural killer cells, which are always going to be important. Natural killer cell activity is enhanced by which of the following molecules? Please remember, natural killer activity is enhanced by 2, 12 and 15. These are the stimulators of the natural killer cells. These are the stimulators of the natural killer cells. So which one fits in your question out here? Interleukin 2. The most important on which you get the question also is this. So NK cell activity is enhanced by interleukin 2. Okay, moving on, going on to the next one. The next one asks you markers of NK cells, and let me tell you, the marker of NK cell is CD16 and 56. These are the markers of the NK cells, whereas CD15 and CD30 are markers of Reed-Sternberg cells. Which lymphoma am I talking about? We are talking about Hodgkin's lymphoma. We are talking about Hodgkin's lymphoma, right? Okay, having said that, I just have to tell you 3 questions about RS cells. If you are asked that which is the marker, which are the markers of the RS cell, if that is what you are asked, please remember the markers are CD15, CD30 and PAX5. Okay, CD15, CD30 and PAX5, of which please remember CD30 is the most sensitive, and so many students have asked me this question over the couple of past few days. Let me clear the confusion. CD30 is most sensitive and PAX5 is most specific. Please, there should not be any confusion on that. CD15, 30 and PAX5 are your markers of the Reed-Sternberg cells. CD30 is the most sensitive and PAX5 is going to be the most specific. I hope it is sorted. What are the markers for NK cells? 16 and 56. Moving on, coming to immunity, basically, we now have to discuss all the mnemonics of hypersensitivity reactions. So let's begin. Let's begin with the very first hypersensitivity reaction, type 1. What is your mnemonic? ABCD. A for allergies, every allergy. Allergic conjunctivitis, allergic dermatitis, allergic rhinitis, every allergy comes over here. Apart from allergy, we also have A for atopy. Atopy means allergy having a genetic component, running in the families, having a genetic determinant. Let me tell you, ATOPY, this is linked to 5q chromosome because atopy has 5 letters. The genetic locus is located on chromosome 5. Atopy, 5 letters, 5 chromosome. B for bronchial asthma. B for bronchial asthma. C for Cassoni test. I hope everyone remembers Cassoni test was a test that was done for hydatid cyst, echinococcus hydatid cyst. And D for drugs like penicillin. So what is the mnemonic for type 1 hypersensitivity? ABCD, atopy, bronchial asthma, Cassoni test and drugs. Coming to mnemonic of type 2 hypersensitivity reaction, and that is my blood group is Rh positive. My blood group is Rh positive. My for myasthenia gravis, blood for any blood transfusion reaction, GR group Graves, and one more if I may add with G, even good pasture. Another thing with G, even good pasture. I for immune hemolytic anemia, immune thrombocytopenic purpura, means platelet breaking down, RBC breaking down, because antibodies are attacking them. Antibodies attack RBCs, they break down. Hemolytic anemia. Antibodies attack platelet, they break down. Thrombocytopenic purpura. So yes, that is. RH stands for RH incompatibility and rheumatic heart disease, RHD. P stands for pemphigus and pernicious anemia. So what's your mnemonic? Quick recap. For type 1 hypersensitivity it was ABCD. For type 2 it is my blood group is Rh positive. Out of these I want to take out this myasthenia gravis and the Graves disease. The grave things I've taken out. Okay, I've taken out the myasthenia gravis and I've taken out the Graves disease. So please remember, these are now classified as type 5 hypersensitivity. They have been reclassified. So many students ask me that, ma'am, now if the question comes to choose between 2 and 5, what will I select? See, if option says myasthenia gravis is which hypersensitivity? 1, 2, 3, 4. It's simple, you don't have 5 written, so you'll go in for 2. If it says which hypersensitivity? 2, 3, 4, 5, then you are stuck. So remember, go with the latest one, then select type 5 hypersensitivity. Having done this, coming to type 3 hypersensitivity. Type 3 hypersensitivity has a mnemonic known as SHARP. What is SHARP? S for SLE, serum sickness and Schick test. Okay, SLE, serum sickness and Schick test. H for Henoch-Schönlein purpura. A for Arthus reaction. R for Raji's assay. P for PSGN, PAN and late complications of parasites. I'll repeat. What is SHARP? S for SLE, S for serum sickness, S for Schick test. H for Henoch-Schönlein purpura. A for Arthus reaction, R for Raji's assay, P for PSGN, PAN and parasitic diseases. Type 3 hypersensitivity done. Coming to the last one, type 4. Type 4 is cell mediated hypersensitivity. 1, 2, 3. Hypersensitivity 1, 2, 3 were antibody mediated, and type 4 is the only one which is cell mediated. Examples, all examples of granulomas come up over here. Number 1. Number 2, there's a skin test. Now tell me, granulomas means TB, leprosy. They are showing type 4 hypersensitivity. So what is the test for TB? Montu's test. What is the test for leprosy? Lepromin test. So can I say skin tests are also type 4 hypersensitivity? Contact dermatitis. Contact to, in India for example, contact to artificial jewelry. Contact to artificial jewelry, because you know artificial jewelry has a lot of nickel and cadmium, so they can cause contact dermatitis. Whereas in the world it is not to do with artificial jewelry. In the world it is to do with poison ivy. Poison ivy. Yes, are we clear with the 5 types of hypersensitivity reactions? Type 1 is ABCD. Type 2 is my blood group is Rh positive. Take the myasthenia gravis and Graves disease out of it, put it under type 5. Type 3 hypersensitivity mnemonic is SHARP, and type 4 hypersensitivity is mostly all the granulomas. Having discussed it, we have a list of controversial entities which you have to know. Please remember, rheumatoid arthritis is 3 and 4. Hypersensitivity pneumonitis is 3 and 4. Please remember, both of them are mixture. Okay, coming to this one, SLE. The way I write SLE, I'm going to flip the S, I'll get a 2. I'm going to flip the E, I'm going to get a 3. So which combination do we have in SLE? We have type 2 and type 3 hypersensitivity reactions. Okay, coming to transplant rejection. Hyperacute within, the one that happens within 48 hours or on the OT table itself. has only 2 involvement. Acute and chronic has both 2 and 4 involvement. Is this clear? So rheumatoid arthritis, hypersensitivity, pneumonitis is 3 and 4. Okay, hyperacute transplant rejection is 2, acute and chronic are 2 and 4, and SLE is the easiest to remember. Flip the S, flip the E, you will get 2 plus 3. So there's no, there's no harm in making this mnemonic, you will never forget it hereafter. Having discussed the mnemonics of hypersensitivity, now let's go on to an MCQ where I test another knowledge of yours on the topic amyloidosis. Which of the following is or are stains of amyloid? Which of the following is or are stains of amyloid? Congo red, methyl violet, thioflavin T, PAS or crystal violet? Please remember all of these. That is exactly why I got this question. I wanted you to know that all of these are stains for amyloid. Congo red, the 2 violets, that is methyl violet, crystal violet, thioflavin T and PAS. But the most important one that we use is Congo red. So if this would have been a single best answer, then you would have gone for Congo red, that that's the best of the list. But here they've given you options that select the combination. So if you see, then A, B, C, D, E, all of them are stains for the amyloid. Moving on, out of these, Congo red is the most important. So Congo red is going to stain is going to stain amyloid. Obviously it is going to stain amyloid, but please remember whether you see it under light microscope or polarizing microscope makes a lot of difference. If you see it under light microscope, see you have a slide where you feel that tissue has amyloid, so you add Congo red. You see it under light microscope, you will get a salmon pink color, and you will feel that everything in pathology is anyway pink, so what is different? So that is why light microscope is not confirmatory. It suggests you that okay, there is some pink color material present, maybe it is amyloid, confirm it. So please remember, they do a polarizing microscopy and find out this image, that is apple green birefringence. So polarizing microscopy is done and apple green birefringence is obtained. I hope everyone is clear about Congo red. One question is always expected. Moving on to the next question. All are affected in GVHD except, we are basically talking about graft versus host disease. Graft versus host disease. So what is GVHD? For example, there's a patient and in that patient you have put in a kidney. You have transplanted a kidney into him. So what happens? This kidney is very smart. This kidney starts going and attacking this patient. The kidney that you've placed for better lifestyle, better life, and the kidney that you've placed for a failing kidney, you've done a transplant, but that kidney is very smart, it starts going and attacking the person. That is graft versus host disease. So see, if you reject the kidney, you have rejected the kidney, you have done it, means transplant rejection, you have rejected it. But what is graft versus host disease? That kidney is attacking the person. It is kidney is attacking the person. Please remember. And whether you say GVHD, you actually have to classify as acute and chronic. And yes, there is a criteria of 100 days. Anything acute, 100 days. After 100 days becomes chronic. After 100 days becomes chronic. So graft versus host disease affects which 3 organs? It affects the skin, the liver and the intestine. Which organ does it not affect? All are affected except, remember, lungs. So skin, liver, intestine. Skin, liver, intestine, these 3 are the ones which are going to be affected by graft versus host disease. Moving forward, going on to a simple one-liner question which I had taught you on the Unacademy platform. Let's see how many answer. Earliest histopathological change in myocardial infarction. Histopaths change. Whenever I say histopaths change, I refer to light microscopy. When I want to say ultrastructural finding, I want to signify electron microscopy, something advanced that I'm doing. So histopath will mean light microscopy, and going by light microscopy answer, your answer should be waviness of the fibers. So in that entire complicated table, there are 3 to 4 dates which are of utmost importance. We are going to make that because then you will get to know how how I marked waviness of fibers. So here we have, there are taking out the salient features that are there. The first electron microscopic change, let me tell you, everyone knows that within 20 to 40 minutes, average 30, okay, 30 minutes is the time in the heart for reversible cell injury. 30 minutes is the time in the heart for reversible cell injury, thereafter it is irreversible. So during these 30 minutes, only one change is seen in the mitochondria, that is mitochondrial swelling. So which microscopy would this have been seen in? Mitochondria, electron microscopy. So within 30 minutes, mitochondrial swelling. After 30 minutes up till 4 hours, the first light microscopic change comes, and that is waviness of cardiac fibers. After 4 hours, finally you can see something with the naked eye after 4 hours, and that is mottling. So within the first 30 minutes, what do you see? The electron microscopic finding, that is mitochondrial swelling. After that, 30 minutes to 4 hours, which ones do you see? The light microscopic changes, that is waviness of cardiac fibers. And finally, after 4 hours, you are able to see the mottling. I hope that is clear with everyone. Coming to the next one, which is the most common primary cardiac tumor of heart valves? I remember everyone, most of you had given me a wrong answer to this despite knowing the answer. They've asked you primary, so metastasis is ruled out. Cardiac tumor, which should raise suspicion. Cardiac tumor primary of the heart is very rare, but they have written of not the full heart, of the heart valves. Please remember, papillary fibroelastoma. Papillary fibroelastoma. Papillary fibroelastoma is the most common heart valve tumor. So if I ask you a very quick question, that which is the most common cardiac malignancy, so you will clearly say the most common cardiac malignancy is metastasis. It is metastasis, number one. Number two, which is the most common cardiac abnormality in adults? Which is the most common cardiac abnormality in children? Okay, so if I say cardiac abnormality, by here obviously I want to say tumor. So which are the answers? I want everyone to say. So don't get confused with abnormality. I'll call them cardiac tumor. Okay, I'll call it cardiac tumor. Most common cardiac tumor in childhood and most common in adults. I hope everyone's got the answer. In adults it is myxoma, yes. And what is the answer for children? It is rhabdomyoma. So there's another question. Which out of these is seen where? Please remember Mr. Please remember Mr. Myxoma is seen in left atria. Rhabdomyoma is seen in left ventricle. So M and R, Mr. Myxoma and rhabdomyoma. Which out of these shows spider cells? Please remember, rhabdomyoma microscopically is going to show you the presence of spider cell. I hope that is sorted with each one of you. Yes, so coming back, which is the most common cardiac valve tumor is papillary fibroelastoma. But coming to the most common cardiac malignancy, that's METS. Most common cardiac tumor in adults is myxoma, seen in the left atria. Most common in children is rhabdomyoma, seen in the left ventricle, shows you presence of spider cells. Moving on to the next question, the very bread and butter of the subject. Correct order of gram staining is, so you need to know that mnemonic so that you can pick up the gram staining protocol and put it in order. Yes, so we have option number, very good, we have option number B. I hope everyone got it. Crystal violet, iodine, acetone and safranin. Yes. So guys, what is the gram staining protocol? Here it is. It is a simple mnemonic, that is come in and stain. If you want to learn how to stain, come in the laboratory and learn. Come in and stain, CIAS. CIAS. Crystal violet, iodine, alcohol. Some people use alcohol, some use acetone, okay? Alcohol or acetone and safranin. So what is it? Crystal violet, iodine, alcohol or acetone and safranin. That is the staining protocol of gram stain. I hope it is clear exactly what was asked. So we have crystal violet, iodine, acetone and safranin. Come in and stain. I hope that is clear with everyone. Moving forward, and this is, these kind of questions are pretty much expected. Moving forward, Sporulation occurs in this phase of the bacterial growth curve. Bacterial growth curve is by far one of the most expected and important questions. Sporulation occurs in the phase of bacterial growth curve. S for S, yes, sporulation occurs in the stationary phase. It occurs in the stationary phase. One more question. Which of the following is true regarding the lag phase? True regarding the lag phase. Period of active growth without increase in numbers. Okay. Next, growth occurs exponentially. Growth occurs exponentially is lag phase or log phase? Exponentially always means log phase, right? So it is log phase. The plateau in lag phase is due to cell death? No, not at all. There's no cell death in this lag phase. And the second phase, it is in the second phase of bacterial growth curve? No, the lag phase is in the first phase of bacterial growth curve. So which is the correct statement? It is a period of active growth without increase in numbers. Yes, so you will understand this when you see a proper growth curve. See, this is the bacterial growth curve. It starts off with a stagnant phase, that is lag phase. Then it rises exponentially. The bacteria grow exponentially, known as log phase. Then comes a plateau. Complete straight line, and that is stationary phase. Stationary. And then comes a decline, so you call it a decline phase. So what are your sequence? Lag, log, stationary, decline. Please note the lag phase, this phase of the growth curve, the first phase, it is a time for cell adaptation. It is a time for cell adaptation. The cell grows in size, brings in all enzymes, metabolites, is preparing itself. Okay, cell is adapting, cell is preparing itself by increasing the size. I hope this is clear. So how will you remember lag phase? Lag phase, cell is just sitting over here, like most of us in the lockdown. So just sitting over here and gaining weight. The cell is sitting over here and gaining weight and is restoring all the energy. So humans are just sitting at a place, gaining weight and restoring all their energy that they've lost out earlier. So that is lag phase. Coming to the log phase, obviously you can see it's going exponentially up. This means there is exponential division. There's exponential rise in the number that is happening. Means the cells are going to show uniform staining and maximum activity. Uniform staining is noted. Coming to that plateau phase, the stationary phase, you know why it becomes stationary? Neither is it rising nor is it falling, because the number of the living cells is equal to the dead cells. If the number of the living cells is equal to the dead cell, will you get uniform staining? No, non-uniform staining. Please remember the way you write stationary. This is stationary phase, right? This is stationary phase. The way you write stationary, S for sporulation, T for toxin production, and A for antibiotics. If they ask you in which phase will you see sporulation, in which stage will you see toxin production, and in which phase of the bacterial growth curve will you see antibiotics production, so you are going to say the antibiotics, you are going to say the stationary phase, STA, sporulation, the toxin production and antibiotics. I hope it is clear. Finally, decline phase. Decline phase means that there are cell deaths and involution forms are seen. That is why the curve is dipping. So if I show you the quick curve again, number one, you had the lag phase, the flat one, where the cell is just sitting and becoming fat. That is, size is increasing. Then comes the log phase, where the number is increasing. Then comes the stationary phase, where S for sporulation, T for toxin production and A for antibiotics. That's the stationary phase. The live cell is equal to the number of dead cells. Coming down, the number of the dead cells are going to increase, so there's a decline phase. I hope everyone is sorted with the bacterial growth curve. One question certainly expected. Okay, so which of the following is false about Cushing's ulcer? Which of the following is false about Cushing ulcer? It is a superficial ulcer seen most commonly in the stomach, associated with meningitis, and all statements are true. So rather than teaching you this question, I'll quickly just teach you about the Cushing's ulcer. I'll just teach you about Cushing's ulcer and you'll automatically know the answer. See, when I'm saying Cushing's ulcer, it is going to be an ulcer that is seen in response to increase in intracranial tension. It is seen because of an increase in the intracranial tension, and please remember S. It is going to be seen in the stomach. It is seen in the stomach, and Cushing basically means pushing. Is it a superficial ulcer or a deep ulcer? Please remember, it is a deep ulcer because it can be even associated with perforations. So please remember, when you're talking about Cushing's ulcer, so please remember Cushing has the S, so it is the stomach where these ulcers are seen. Why are they seen? Because of increase in intracranial tension. And are they superficial or deep? They are deep. Cushing ulcer is pushing ulcer. Cushing is pushing. Which is the other ulcer like this? There's also something known as curling ulcer. What is curling ulcer due to? The reason? Curling is because of burning. So it is seen in burns. It is seen in burns, definitely. So curling is because of burning. And is it a deep ulcer or a superficial ulcer? So you'll say Cushing was pushing, Cushing was deep, curling is superficial. Curling is superficial. I hope that is clear to everyone. So definitely the answer in the previous one was that Cushing is not superficial, it is a deep ulcer. Coming to the next one. All of the following are true for GIST except. Now let me tell you, GIST related questions are very, very important. What is GIST? GIST stands for gastrointestinal stromal tumor. So you can very well see from the word, it is going to occur in the stomach, it is going to occur in the intestine. So gastrointestinal stromal tumor, of which please remember stomach is the more common. So the word that comes first is given priority. Gastrointestinal stromal tumor is gastro is the more common area. So yes, it is seen in the stomach. Okay, so what are the cells of origin? It originates from the cells of Cajal. This is a true statement. It originates from the cells of Cajal. Which mutation is seen? It is a true statement. c-KIT mutation is seen. So please remember, there will be a cell of Cajal. In that cell of Cajal, there will be a c-KIT or CD117 mutation. There is a c-KIT or CD117 mutation, as a result of which patient will land up with GIST. Patient will land up with GIST. So okay, originates from cells of Cajal, c-KIT is seen. It is the most common mesenchymal tumor of the GIT. Yes. See the word gastrointestinal stromal tumor. This is the most common mesenchymal tumor of the GIT. Majority are seen in duodenum. No, majority are seen in the stomach because that's the word. GIST. Last question. Which is the most sensitive marker for GIST? Which is the most sensitive marker and which is the most specific marker? Which is the most sensitive marker and which is the most specific marker? Let me tell you, the most sensitive one is CD117. Does this remind you of the mutation? Yes, CD117 is the most sensitive and DOG1 is the most specific. DOG1 is the most specific. I hope everyone is sorted with this, no confusion, right? Moving on. Conjugated hyperbilirubinemia is seen in, it is seen in Crigler-Najjar type 1, 2, Gilbert or Dubin-Johnson. Conjugated hyperbilirubinemia. So when I'm talking about increase in bilirubin, that could either be an increase in unconjugated bilirubin or it could be an increase in the conjugated bilirubin. If it is an increase in the unconjugated bilirubin, please remember you will have Crigler-Najjar type 1, Crigler-Najjar type 2 and Gilbert syndrome. These three come under the unconjugated hyperbilirubinemia. Whereas, which are the conjugated ones? Dubin-Johnson, you have Dubin-Johnson and we have Rotor syndrome. So how will you remember this? Please remember the doctors are going to always remain conjugated. Doctors will remain conjugated together. So Dubin-Johnson and Rotor are conjugated and the other ones are unconjugated increase. What are the other questions that you get? Crigler-Najjar type 1, 100% fatal. There is no coming out of it. Child will not survive. 100% fatal. Okay. Dubin-Johnson, D for Dubin, D for dark. Dark color liver. Dark color. So if they ask you which of the following shows the presence of a pigmented liver, it is D for Dubin-Johnson, D for dark. It is Dubin-Johnson syndrome. Okay, so now let's see the other question. Which of the following hyperbilirubinemias are autosomal dominant? Crigler-Najjar type 1, 2, Gilbert or Dubin-Johnson. So let me tell you from the same. All of these are autosomal recessive. Okay, all are autosomal recessive except. So they've asked you which is autosomal dominant. Crigler-Najjar type 2. Why? How will you remember this? That is autosomal dominant. How will you remember this? Crigler-Najjar type 2. 2 means though, and though will remind you of dominant. Though will remind you of dominant. So Crigler-Najjar type 2, though, that is dominant, rest all are autosomal recessive. Moving on to the next one. I've just taught you which of the hereditary hyperbilirubinemias is the most fatal. I just told you Crigler-Najjar type 1 is said to be the most fatal. Moving on to the next question. Onion skin fibrosis is seen in. Okay, I hope everyone knows the answer to this question. It's a rather simple one. Onion skin fibrosis is seen in primary sclerosing cholangitis. So I'll quickly teach you what are these, what diseases am I talking about? Biliary diseases, pretty much expected in the paper. Please remember, biliary diseases are of two types. It will be written as PBC and PSC, so be very familiar with it, okay? It is primary biliary cirrhosis. So PBC, primary biliary cirrhosis, and the other one is primary sclerosing cholangitis. Primary sclerosing cholangitis. Okay, PSC. Biliary diseases, look what I'm highlighting, I and I. In sclerosing cholangitis, E and I. You're looking out for the vowels. See, I and I means intrahepatic bile duct is affected. It involves the intrahepatic bile duct. Whereas sclerosing has E and I means extra and intrahepatic bile duct is affected. Extra and intrahepatic bile duct is affected. Please remember, primary sclerosing cholangitis is associated with P ANCA, and primary sclerosing cholangitis shows you the onion skinning pattern. Please remember, this PSC is pretty much expected in your paper. To repeat, sclerosing E and I, the defect is in extra and intrahepatic bile duct. Which antibody? P ANCA. What is the appearance? You get onion skinning pattern. I hope it is clear with everyone. Okay, coming to the last thing for this session, or maybe second last. Okay, and I hope everyone is in track with it. What accumulates in the space of Deci in fibrosis? So first and foremost, what is space of Deci? So if these are your hepatocytes, this is one row, this is another row. Quickly I'll tell you, because all space of Deci questions are important. It's in the liver, okay? So this is hepatocyte, and in between what do you have? You have blood vessel. Basically you have sinusoid. So what do you see? Do you notice between the hepatocyte and the sinusoids I've made a space? Everyone agrees to that? What is this space known as? This is known as the space of Deci. This is known as space of Deci. So what is it in between? It is between the hepatocytes, liver cells, and the sinusoids. What all does it contain? Please remember, space of Deci contains ito or stellate cells. It contains ito or stellate cells. Ito cells are responsible for vitamin A storage. And stellate cells are going to be responsible for laying down the collagen, and that is what is asked. Which type of collagen? So please remember, collagen 1 and 3 is the answer. That is what is accumulated in space of Deci, right? So space of Deci, collagen 1 and 3. What is it coming from? Space of Deci has a cell known as ito cell, which is responsible for vitamin A storage. It also has a stellate cell which is going to basically lay down collagen. Which collagen? Collagen 1 and collagen 3, and that is the reason that the patient lands up with cirrhosis, because so much of fibrosis has happened. That is the reason patient lands up with cirrhosis. Okay, telling you something more about space of Deci. This is the first place in the liver where amyloid gets deposited. The first place in the liver where amyloid gets deposited. Okay, asking you as a collateral question, not related to this, but certainly important for your paper. If they ask you that which are the oval cells, so let me tell you, oval cells are stem cells of the liver. Oval cells are stem cells of the liver, and where are they present? They are present in the canals of Hering. They are present in the canals of herring. So don't confuse them with ito cells. Ito cells were storing all your vitamin A. All the mangoes that you've eaten in the summer months now, all that vitamin A goes into ito cells. Where are ito cells present? Space of Deci. But what about oval cells? Oval cells are present in the canals of herring, and these are going to be nothing but the stem cells of the liver. Moving on to the next question. Thorium induced tumor of the liver. Thorium induced tumor of the liver, let me tell you, it is angiosarcoma. So please remember, in the liver, angiosarcoma is associated with 3 chemicals. What are the 3 chemicals? They are the VAT chemicals. Why do I call them VAT? V for vinyl chloride. These are the chemicals which can cause angiosarcoma. Vinyl chloride, A for arsenic, and T for thorotrust. Vinyl chloride, arsenic, and thorotrust. So what if they ask you thorotrust? Means thorium induced tumor. Thorium induced tumor is angiosarcoma. Again repeat with me, vinyl chloride, arsenic, thorotrust. Last 2 questions of this session. Which breast cancer shows this characteristic histopathological pattern? I showed this image to you on the last day when we were discussing pathology images on Unacademy, just 2 days back. What is it? Do you see cells are arranged one behind the other like army men? Yes. Does this remind you of something known as Indian file pattern? Does this remind you of what I told you, Indian file pattern? Cells are arranged one behind the other like army men, and that is seen in a cancer known as lobular carcinoma of the breast. Do you remember which mutation I told you for lobular carcinoma? There is a loss of E-cadherin. There's a loss of E-cadherin. In fact, I had put this question in part 1 of this series also. Loss of E-cadherin is very, very important. Okay, moving on. Last question of this session. The tumor marker for the tumor showing this characteristic body is. So first and foremost, you should be able to identify the body, and then you will tell me the tumor marker, and this is a very important question. So first and foremost, what do you see? In the center, you see a blood vessel. In the center, I see a blood vessel. Then I see these tumor cells. I see a row of tumor cells, right? Tumor cells. Then I see a whitish space. Okay. And then I again see blue color tumor cells around it. So what do I see? Quick revision. First I see a blood vessel, then I see a tumor cell layer, then I see a space, and then I again see tumor. So after a space, I am again seeing tumor. What is this known as? Schiller-Duval body. Blood vessel, tumor, space, tumor. Again, blood vessel, tumor, space, tumor. This is known as a Schiller-Duval body, also known as, this is a Schiller-Duval body, also known as a glomeruloid body, and that is something you see in yolk sac tumor. So now all that you have to do is find out the tumor marker. Let me tell you the catch in this question. Alpha fetoprotein everyone knows, but even alpha-1 antitrypsin is a tumor marker for yolk sac tumor. So the ideal answer over here is both. The answer to the question is both. So remember, predominantly AFP, but also alpha-1 antitrypsin. Okay, one last question, genuinely the last one. Highest concentration of all rods is seen in which variety of AML? So do you notice these cells over here? Do they have one rod inside it? Do they have like one rod inside it? No, they are full of rods. They are full of OR rods, yes. So first and foremost, such a cell, these rods are known as OR rods, first thing. And whenever I see OR rod, I am very, very confident that I am dealing with a myeloblast. Will a lymphoblast have OR rod? No. Myeloblast has OR rods, number 1. Number 2, when you see a cell which has lots and lots of OR rods, OR rods are all crossing each other. All the OR rods are crossing each other. You call these, when I say OR rods are crisscrossing, when the OR rods are crisscrossing, you call these Faggot cells. These are known as Faggot cells. And where do you see this? In which variety of AML? You see this in AML M3. What is the other name for AML M3? APML. Acute promyelocytic leukemia. Let me tell you guys, that when you're dealing with acute promyelocytic leukemia, it is AML M3. It will show you translocation 1517 known as PML RARA, very important question. It is the AML that is associated with the cells that I showed you, that is Faggot cells. It is the only leukemia that is associated with DIC, the most expected question, please mark my words, the only leukemia associated with DIC. And lastly, for the treatment, you give ATRA, all trans retinoic acid. Everyone, please mug it up. This is very, very important information that you have about AML-M3. It is AML-M3 or APML. Translocation 1517 is seen, which is PML RARA. These are Faggot cells also, which I showed you right now. These crisscrossing each other. Remember, these crisscrossing each other, or rods, Faggot cells. This is the only leukemia that is associated with DIC, and the treatment is all trans retinoic acid. So, well, that is it for this particular session, that is part 2. We have another session coming up, that is part 3, where I'm again going to discuss a mixed bag. What is most the thing that you should look forward in that session, I'm going to discuss the main images of blood banking, questions related to shelf life of the different blood products, the storage temperature of blood products. Also, I'm going to tell you and revise with you the color coding of the vacutainers, which is very, very important. I'm going to revise with you certain culture media and certain stains which are important and which will be asked to you in the paper. So yes, that is what you have to look up to in the next session, and also quick few one-liners related to microbiology also coming up. So yes, a packed session for sure, but I hope these 3 sessions are giving you the confidence that you need right now. I think most important to become, to be successful tomorrow and to get that 150 target that you are aiming for, and actually much more. I'm very confident about it. Okay guys, so that's it for part 2. See you all in part 3 of this Target 31st August series.